It's become a very, very popular drug in the U.S. It's this class of drugs, as I showed you earlier, is in the top 3. And it'll come up again when we talk about pre-diabetes. So I think that pre-diabetes is a term that I personally don't like. There is no such thing as pre-diabetes, as I will try to convince you. There is a normal progression from people who have normal glucose tolerance to a new term that we've discussed called pre-diabetes to pre-diabetes to diabetes. So this task force in the U.S. is pretty much known worldwide, and they have made a recommendation about what you need to know about a particular disease. We're going to talk about diabetes today, to know if it's appropriate to do screening. So if we're talking about diabetes, is the disease serious? I think we all agree the disease is serious. Do we know the natural history of the disease? Well, we do know the natural history. You don't all of a sudden go from normal glucose tolerance to diabetes. That's a misconception. Can we detect it at a preclinical state? And yes, we can detect diabetes as a preclinical state. Is there a screening test? And yes, there is a very easy screening test. You can use the fasting glucose, or even easier is the A1C. Remember, you don't have to be fasting to measure the hemoglobin A1C. So someone can walk into your office in the afternoon, morning, even if they ate. The A1C will give you valuable information. Do we have effective therapies? And we do have very, very effective therapies in the United States as well as here in Turkey. There are no sort of approved therapies by the Food and Drug Administration. Personally, I think that's a big problem. In the U.S., in order to get a drug approved by the FDA, you have to show that it either has cardiovascular protection or microvascular protection. So if you're starting at the pre-diabetic stage and you want to show your drug gives you cardiovascular protection, I actually did this calculation. You'd need about 16 years of follow-up, and you need about 20,000 people in the study. So this is not a study that any pharmaceutical company is going to do. We'd also like to know that if you intervene early, that's more effective than waiting to later in the disease, and that data is available in type 2 diabetes. And we know that if you screen and you intervene, we know from the DCCT and UKPDS and other studies that early intervention makes a difference. So this U.S. preventative force concluded that type 2 diabetes actually meets all of these criteria. And in 2014, they actually did recommend screening. The problem, as I said, there's no drug that's approved by the FDA. So if you're going to prescribe treatment other than lifestyle, then the insurance companies are not going to reimburse the treatment. So who should you screen? Obviously, Dr. Abdul Ghani is not here. He has very many clever statements. And one of his statements was, getting old, aging is a bitch, and then you die. The unfortunate thing, as we get older, things in generally get worse. And so if you're over the age of 45, we know that there's an age-related decline in insulin sensitivity and beta cell function. We know, you've heard this earlier, obesity is a major risk factor for diabetes. If you have a family history, mother, father, brother, or sister, that's a major risk factor for diabetes. We heard in Professor Kanat's talk earlier that gestational diabetes, that's a major risk factor. PCOS is a major risk factor. And we also know that in certain ethnic populations, so the Indian population in the United States, the Mexican-American population, blacks, there's an increased incidence of diabetes. So all of these risk factors suggest that you should go ahead and screen. And the American Diabetes has published an online list. You can just hit this screening for diabetes ADA, and there are 10 factors, and you get a point for each one of these things. And then if you get a score that's above 10, they recommend that you go have an A1C test. Now, how do we make the diagnosis of diabetes? Quite frankly, in my opinion, this is very confusing. So in the old days, it was very easy. We did an oral glucose tolerance test, and if your 2-hour glucose was 200, you have diabetes, less than 140, normal. So we had this range, 140 to 199, and we called this impaired glucose tolerance. And then people were too lazy. They don't do OGTTs, so we came up with the idea of we'd make the diagnosis on the basis of the fasting glucose. So we have IFG with your fasting glucose 100 to 129, and then people are too lazy to even get a fasting glucose, so now we had a hemoglobin A1C value that's 5.7 to 6.4. The problem is all of these diagnose very different things. So IGT is a disease primarily of insulin resistance in muscle, and beta cell failure, and it's associated with accelerated cardiovascular disease, okay? IFG is primarily a disease of the liver, of hepatic insulin resistance. It is not associated with the increased incidence of cardiovascular disease. And personally, the work Dr. Abdul-Ghani and I were the first to show, if you want the best diagnostic criteria, and we've looked at this in a huge number of people, the best diagnostic criteria of who's going to develop diabetes is the 1-hour glucose during the OGTT. If it's greater than 155, that is much better than either using the fasting glucose, the A1C, or the 2-hour glucose. And there was recently a big international symposium. Since our initial publication, there were many other people who looked at the 1-hour glucose. Virtually everybody who's looked at this, literally 100% of people have all concluded that the 1-hour glucose, 155, is the best predictor. And this international group actually advocated changing all of these screening procedures to the 1-hour glucose. And the ADA put together a panel to look at it, and at this point, they decided not to change anything. But as we go forward, I suspect that the 1-hour glucose will move up. So when do we start to treat people? Do we wait till they get diabetes and they meet all of the criteria that are out there? Do we start at the pre-diabetes stage, and I've gone through the criteria which we make the diagnosis? Do we start at the pre-diabetes stage? So there's a question mark, okay? So I'm going to take you through what we know, and then at the end, I'm going to repose the question, and we'll take an audience poll. So what you all think should be done now, okay? So how many people in the room would wait? There's no right answer to this, by the way, and you have to respond. How many people would wait till someone develops overt diabetes by any of the standard criteria? Put your hand up. Okay. How many people, so there are a few hands. How many people would actually pre-screen, and at the time you make the diagnosis of the, quote, pre-diabetes, who would screen at the pre-diabetes stage? So a lot of hands. My hand went up with you folks too. Now, how many people would screen at the pre-diabetes stage? How many people even know what the hell the pre-diabetes stage is, okay? So there are some criteria we developed. So no hands go up. Maybe I would put hands up for both, okay? So we'll see what you think as we go through this. So I'm not going to go through the pathophysiology again because I already did it with you. Insulin resistance in the liver, overproduction of glucose throughout the sleeping hours, fasting hypoglycemia. This is impaired fasting glucose, okay? Insulin resistance in the muscle. This is postprandial, postmeal hyperglycemia. This is IGT. Beta cell failure in people who have IGT, they lose first phase and second phase insulin secretion. The people who have IFG, they lose first phase insulin secretion. These are completely different diseases, okay? And what drugs should be used to treat IGT versus IFG, I would say, is very controversial, so no one has ever done this. So we actually have a big NIH-funded study. We presented the one-year data at the ADA this year, and it turned out that the best drug to treat whether you have IGT or IFG is pioglitazone. Destroyed everything else, but as I'm going to show you, probably things will change because the GLP-1 receptors were not in this study. So when does this disease start? So these are data from two big studies, the San Antonio Metabolism Study and the Veterans Administration Genetic Epidemiology Study that we've carried out in San Antonio. And there are literally hundreds of people in this study. And we did insulin clamp studies to measure insulin sensitivity. And what I'm going to plot now is I'm going to break the group down who has, quote, normal glucose tolerance based on the fasting glucose concentration. So if your fasting is less than 100, you have NGT. But you can see, if I break them down less than 90, 95, or 100, you can already see at this sort of upper tertile of, quote, normal glucose tolerance, there's already a significant reduction of about 10 to 15% in their insulin sensitivity. And this is measured by the gold standard insulin clamp technique. So remember, we're going to infuse insulin, and then with radio-labeled glucose, we can precisely quantitate glucose uptake by all the tissues in the body. So now I'm going to add the people who have impaired fasting glucose, meaning they're between 100 and 126, and now you can see there's a huge decrease in their insulin sensitivity. So in this pre-diabetic stage, they've gone from about 45 down to about 30. They've lost 35 to 40% of their insulin sensitivity. So clearly, in the pre-diabetic stage, they're insulin resistant. In the pre-diabetic stage, they're insulin resistant. And now, if we add the diabetics, and I've just broken them into 4 equal quartiles, by the time you've developed diabetes, you are maximally insulin resistant. Maybe you get a little bit more insulin resistant, but for all practical purposes, when that diabetic walks into your office, they're already sort of maxed out in terms of their insulin sensitivity. Again, I think this shows very clearly this is a continuous disease. This doesn't all of a sudden start. You go from normal glucose tolerance. So one could make the argument that the earlier you start, if you think that insulin resistance is important, and I think it is important in terms of atherosclerosis generation, you could argue that you should start earlier, okay? Now, what about the other side of the story, beta cell failure? Well, just like we've learned about insulin resistance, beta cell failure occurs much earlier in the natural history of diabetes, as I'm going to show you, and it's much, much more severe even than the development of the insulin resistance. So what I'm going to plot for you in this study is this is the disposition index. This is the gold standard for beta cell function. I'm going to look at the increment in insulin per increment in glucose during the OGT, and then factor it by how insulin resistant you are. And here I'm going to plot it against the 2-hour glucose concentration, okay? So if your 2-hour glucose concentration, according to the American Diabetes Association, so you get the impression I don't agree with anything that the ADA says, and that's true. And the fact is, I'm never wrong. So you can either look at the ADA criteria or you can believe what I'm going to show you, okay? So what you can see here, in the upper tertile of, quote, normal glucose tolerance, you already lost 50% of your beta cell function, okay? And I already showed you these people are already insulin resistant. These people already have diabetes pathophysiologically. Forgetting about picking some magical number, if you talk about pathophysiology, If you've lost 50% of your beta cell function, that's very, very abnormal. And this is a huge study with hundreds of people in this study. Now, if I had the people with, quote, impaired glucose tolerance, so between 140 and 199, you can see that these people in the upper tertile of, quote, prediabetes, they already lost 80 to 90% of their beta cell function. And I already showed you earlier, they're pretty severely insulin resistant. And you don't have to lose much more. You lose 5% of your beta cell function, and your 2-hour glucose goes from 190 to 300. And the reason for that is because when your glucose is in this upper range here, you really have lost so much beta cell function, you use a little bit more, and you get just a huge increase. So again, the first red arrow to emphasize, within the range of normal glucose tolerance, you lost more than 50% of your beta cell function. And then in the upper tertile of, quote, pre-diabetes, you lost 80 to 90%. So you can argue, where does the disease start? In the pre-diabetic stage? Or does it start in the pre-diabetic stage? Okay? Or could you argue that it starts when you were born and your parents gave you the wrong set of genes? And now that you've got the genes for diabetes, now you are very much predisposed. And this comes back to what Mustafa said. The maternal environment dramatically influences that baby who's developing, and when the mother is exposed to excess caloric intake, and you can make the argument for the opposite, the data are equivalent, if they're undernourished, the incidence of diabetes and lifelong obesity goes up dramatically. Now, things in everyday practice don't happen in absolute terms. They happen as a log function. So what I've done in this slide is I've just taken the log of the 2-hour glucose on the x-axis, and I plotted it against the log of the beta cell function index. And it's very clear. Here are the NGT people. Here are the IGT people. Here are the diabetics. This relationship is incredibly linear. And you never see an R value like that in any human study. It's 0.91. So again, what it's saying is this is something that it happens linearly in life. It doesn't all of a sudden just occur. And now, if I were to obliterate the color, if I'm a magician, and look, I just obliterated the color. And now I tell you, go up there, tell me where you would put the line for, where's the difference between NGT and IGT? Would you put the line here, here? Where would you put the line for diabetes, okay? It's completely arbitrary. Why? Because there's not a break point that you can say this is pre-diabetes and this is diabetes. It's a continuous decline in beta cell function. And so one can make the argument that the earlier you treat, the better or more likely you are to prevent the development of diabetes, okay? Now, what about beta cell mass, okay? Because I told you earlier, once you lose beta cell mass, now you're in trouble. So this is a study that Dr. Peter Butler did many, many years ago. He got permission from his institutional review board. The people died. He could go and he could remove the pancreas, and then he could isolate the pancreas, and he counted the beta cell volume. Now, beta cell volume is not exactly equal to mass, but it's pretty close to beta cell mass. He also, the patients are deceased, so he can't do an OGTT, but he can measure the fasting glucose. So here are people with NGT, here are people with IFG. And if you look at beta cell mass, it's already gone down quite significantly. And then, of course, if we add the people with diabetes, they have a higher fasting glucose and a greater decrease in beta cell mass. So not only do we have a decrease in function, we're losing the number of beta cells per se. So again, when do you start to treat, okay? Do you wait till the person is over here? Do you intervene earlier? Or maybe even at the time they have normal glucose tolerance. So if we really want to prevent this development of insulin resistance, and if we really want to preserve beta cell failure and maintain normal glycemia, to me it's very clear that we need to intervene at a very early stage. And as I said, this is a very sort of debatable point because the FDA doesn't have any drugs approved for the treatment of, quote, prediabetes. And the only recommendation the ADA says is if you are a high-risk person, meaning, let's say your A1C is 6.3, and let's say you're obese, you have a history of family diabetes, then they recommend you should consider treatment, not you should treat. And what is the drug? Metformin, okay? So I would argue you could consider whether the ADA's use of the word consider is appropriate. And then I would say you could also consider whether metformin would be the drug that you would use. Well, I can guarantee you metformin would not be the drug that I would use, okay? So treatment now. We're going to come to treatment, and lifestyle, of course, always going to be foundational therapy. But as I told you, other than Roy Terry's study in the United Kingdom, lifestyle intervention is uniformly failed on a long-term basis, okay? So are you going to choose between lifestyle and pharmacologic therapy? Well, of course, lifestyle is going to be recommended to all patients. And at the Texas Diabetes Institute, I told you, we see 10,000 unduplicated patients. We have multiple dietitians. We actually have a gymnasium within the institute. We have 2 physical therapists who work with our diabetic patients. So we're big believers in lifestyle. But my goal with lifestyle is to make sure that the patient doesn't gain any more weight, and I'd be happy. If they're in the 5 to 10% of people who lose weight and keep it off, great. But I also recognize the majority of people, their lifestyle alone is not going to work. So to me, the answer is very clear. These people should be all placed on pharmacotherapy at the beginning, okay? What about dietary? This was, there are 2 big review articles. I put them down here at the bottom for reference. This is a summary. There are over 200 trials now, 46 randomized controlled trials that have gone longer than 16 weeks. And while the people are in the trial, they lose weight. So here's the BMI decrease, but this is over a period of years. And if you follow these people up for 3 to 5 years, you can see within 3 to 5 years, the BMI has returned to normal. So 0.36 kilograms per year, multiply it by 4 or 5, and they've regained all of the weight. So this is really the first big attempt. This is the Diabetes Prevention Program, DPPP. It's a very big study. There are 4 groups in this study. I'm going to show you the first 3 groups, and then I'll add the 4th group in a second. So these people are screened, and then they're going to get standard lifestyle. This is basically what you would do in your practice. Most of us as physicians don't have time to talk to the patient. We send them to the dietitian, and they usually meet with the dietitian 2 or 3 times. And in intensive lifestyle, they had one-on-one 16 meetings, one-on-one with the dietitian, okay, in the first 3 months. And then they had group meetings every month. With regards to exercise, you got your own physical trainer. And the physical trainer worked you out 3 times per week, okay? Your own physical trainer. So if you were a guy, you got the pretty girl who took you to the gym and worked you out. If you were a woman, you got Mr. Atlas who took you to the gym. And this went on for the first 6 months. No one in the world can afford this. And in fact, we probably don't even have enough dietitians and exercise trainers to do this, okay? And then the 3rd group was metformin. We followed people up. So here's the result, okay? Did the diet and exercise work? Absolutely, okay? While they're in the program, if we look at, compared to the standard therapy, there was about a 60% decrease in the conversion rate of, quote, prediabetes to diabetes. So there is no doubt that if you lose weight and you're physically active, it works. That's not the problem. The problem is, can you keep it up for the rest of your life? Metformin, there was a 31% decrease. So actually, the weight loss exercise program did better. So what was the 4th arm? The 4th arm was troglitazone. Now, troglitazone was dropped from the study about a year and a half into the study because it caused hepatotoxicity. They took the TZD molecule and they attached vitamin A to it, thinking that it was a fat-soluble vitamin and it would concentrate in the liver. So it turned out two bad things happened. It did concentrate in the liver, and it led to an abnormal metabolite of the troglitazone that had severe liver toxicity. So troglitazone was removed from the study. But we have 1.5 year data. So here I've expressed the cases of diabetes per 100 patient years of treatment. Lifestyle light, of course, that was the worst therapy. Metformin did okay. Lifestyle heavy is about the same. The best drug actually was troglitazone. But now, if we look at the weight, remember I told you 16 meetings with the dietitian within the first 3 months, having the physical therapist work you out 3 times a week, okay? You lost weight, okay? But then, look, the weight's starting to regain. Metformin did okay. So what happened at year 3? At year 3, they said, uh-oh, we reintroduced the whole program again. And then what happened? They reintroduced the whole program again, and you can see it didn't work at all. Despite the fact they had the dietitian come for 16 visits and the physical therapist. And literally here after 5 to 6 years, you're no better off than metformin. So this proved 2 things. While you're in the program, it works. Once you start to get out of the program, or with time, people get lazy. It's difficult to maintain this kind of lifestyle. Pharmacologic therapy, it works all the time. So here are the studies here. I think there's something very unique, and I don't understand it, but in the Chinese study, they got a relative risk reduction of 77%, okay? I don't think you'll ever see this anywhere else in the world, or I'm not even sure it can be repeated in China. But this is the Indian Diabetes Prevention Program, the U.S. Diabetes Prevention Program. There's about a 30% reduction in the conversion rate, okay? Here are the TZD studies, and you can see a marked difference, anywhere from 60 to 75%. I'm going to tell you a little bit about our study, which is the ACT NOW study. We know that these alpha-glucosidase inhibitors are effective. They're not very well tolerated in the United States. They've not been very popular. And then we have this fat blocker, orlistat, which is effective, but again, it's from the dietary standpoint, the diarrhea makes it not a popular choice. And we have the SCALE study with liraglutide, and I'm going to show you the more recent study with one of the newer GLP-1s, 79, 80%, okay? Qsemia, phentermine, topiramate actually works very well, but again, not a very popular regimen in the US. So here are the TZD studies, and this is the ACT NOW study, okay? Stands for Actus Now for the prevention of type 2 diabetes. So we screened over 1,800 people to find 600 participants in the study. And then we randomized them equally to placebo or to pioglitazone. And these curves started to separate very early. The incidence, the rate in the PO group, 2.1% per year versus 7.6% per year. Hazard ratio is 0.28, means a 72% conversion. Incredibly effective. We stopped the drug, and we followed them up for another year. And at the end of a year, off the drug, the conversion rate in the pioglitazone-treated group was identical to that in the placebo group. So if you're going to treat, you have to stay on the drug. And the same thing I'll show you is true with the GLP-1 receptor agonist. So why did pioglitazone work so well? So we measured insulin sensitivity 2 ways with the insulin clamp and the frequently sampled IVGTT. You see a big improvement in insulin sensitivity with the pioglitazone, no change with placebo. Okay, if we look at beta cell function, this is insulin secretion per amount of glucose times this insulin sensitivity index major improvement in beta cell function. And then from the frequently sampled IVGTT, this is the acute insulin response times insulin sensitivity, big improvement. Nothing differently from what I showed you earlier in the diabetic patients. The TZDs are powerful insulin sensitizers, and what people don't understand is they have a huge effect on the beta cell, okay? Number needed to treat. You need to treat 18 individuals for 1 year to prevent 1 case of diabetes. So to put this into perspective, I think if you had a patient who had a myocardial infarction and their LDL cholesterol was elevated, I think 100% of the people in this room would put them on a statin. With the higher potent statins, atorvastatin, rosuvastatin, the number needed to treat to prevent 1 myocardial infarction is 20. So what's more important? If you had an MI to prevent another MI, or if you have prediabetes to prevent diabetes? I would say they're equally important. So if you're going to treat someone who has hypercholesterolemia to prevent an MI, you should be equally interested in taking someone who's prediabetes and treating them. So now the question is, if you're going to treat someone who has prediabetes, and again, we're going to focus on the insulin resistance part of the story, although the pioglitazone will also attack the beta cell dysfunction. Is there any evidence that if you treat the insulin resistance, that you'll decrease the incidence of diabetes, and what the FDA wants you to do is to prevent cardiovascular disease? And in fact, we have a fantastic study, okay? And this is called the IRIS study. So the first author on the paper is Kernan. The senior author is Inzucci. Dr. Inzucci is the endocrinologist. He's at Yale. Dr. Kernan is a neurologist, okay? So to get into the IRIS study, you had to have a stroke. A stroke is not good. And if you had a stroke, you're very likely to have a recurrent stroke. So this is a big study, close to 4,000 people in the study. And you could not be diabetic, okay? That's the important part. And the A1C is down here at the bottom. The mean A1C is 5.8. What that means, half of the people are between 5.8 and 6.4. They're pre-diabetic. The other half of the people are, quote, normal glucose tolerant, all right? So they have either IGT or normal glucose tolerant. The results I'm going to show you, it doesn't make any difference whether you're pre-diabetic and normal glucose tolerant. The results are going to be identical, okay? And they also had a requirement, you had to be insulin resistant. So HOMA-IR is simply the product of the fasting glucose and the fasting insulin. And if your value is above 3, that's very abnormal, okay? So non-diabetics, insulin-resistant stroke. What happened? Wow, okay? Recurrent stroke and recurrent cardiovascular events was decreased by 24%. And as I said, it didn't make any difference if your A1C was 5.8 to 6.4 or less than 5.8. So we actually have a study showing that if I treat a pre-diabetic population, now, of course, it's a very specified one. They had a stroke, okay? With pioglitazone, I reduce recurrent cardiovascular events. So I would say I could make the argument that, yes, we do have a study that says treating early is important. Moreover, remember, in this study, no one had diabetes. So they could also follow and see what happened. And interestingly, there was a 72% decrease in the conversion rate of prediabetes to diabetes. So this study actually showed that early intervention prevented cardiovascular recurrent events and prevented diabetes. Now, what about GLP-1 receptor agonists in diabetes prevention? So I showed this slide earlier. These GLP-1 receptor agonists, and you heard a very nice presentation about treatment of obesity just prior. They reduce A1C, they work on the beta cell, you lose weight, and when you lose weight, you improve insulin sensitivity. I personally don't believe that these drugs are direct insulin sensitizers. Do they improve insulin sensitivity? Absolutely. We've shown this time over with the clamp. But I believe it's all due to weight loss. And they're safe. They don't cause hypoglycemia. If you want to talk about safety profile, we've had an enormous experience, practical experience with these drugs, both tirzepatide as well as semaglutide. We can review that in the Q&A period. So here's now the conversion rate, percentage of people who are developing diabetes in the placebo group, or is a very long follow-up, versus the liraglutide group, and the hazard ratio is 0.21. Means there's an 80% decrease. It's fantastic, okay? Now, these are the data most recently published with tirzepatide. So this is Jastreboff. She's from Yale. It's a very recent article, 2025. So again, this is the 5 milligram, the 10, and the 15 milligram dose. And here is the weight loss over here. At the top dose, it's about 20%, very similar to what I showed you before. And here now is the pooling of all three of these drugs, the conversion rate versus the placebo, and the hazard ratio is 0.92, meaning there's an enormous reduction. And I can tell you there are actually very similar data with semaglutide as well. So if you had to pick two categories of drugs, you have, I think, excellent choice with the GLP-1, and you have an excellent choice with the TZD. One drug costs $5 a month. The other drug costs $1,000 a month, okay? So cost will always be an issue. I know that the cost of semaglutide and tirzepatide is much less here. I'm told $250 a month. But the fact is that's probably very expensive for people living here in Turkey as well, okay? So what do we know? Diet and exercise works, okay? Metformin works. TZDs work. Alpha-glucosidase inhibitors work. There are a couple of studies. I don't think that they are very popular. And GLP analogs work, okay? So now I'm going to tell you what can you do in the real world, okay? Everything I've showed you, these are big pharmacological studies run by Novo or Eli Lilly or, you know, who got, I'm told that if you look at the kind of stock market, the amount of money that Novo made last year, their income is greater than the total income of all of Sweden. So, of course, they can run these studies. But now you're out in the community, okay? What are you going to do? So I have two friends in California. One is an endocrinologist, the other is a primary care doctor, and they have an interest in diabetes. It's John Armano and Ron Ruby. And they had a number of patients who were referred to them, almost 1,800, for evaluation of, quote, prediabetes and potentially treatment. And initial screening, 1,000, they just said, no, they just clinically lab work, they don't really need to be screened any further. So they enrolled 747 in the study. There were about 300 who were excluded when all of the lab data came back. And there were 422 who were stratified. So how were they stratified? And what I'm going to show you is actually you can do this yourself. And if you want, you can go online and all of the equations that you need to plug in are there. So 81 are going to be assigned to metformin and GLP-1. 141 and pioglitazone. 141 to get pioglitazone and metformin, and 200 are going to get lifestyle. So who are the people who get lifestyle? These were the people who were assessed not to be at high risk, and then there were some not very smart people who we recommended they be treated pharmacologically, and they decided, no, we're just going to do lifestyle, okay? So how do we divide these people? Everybody had an oral glucose tolerance test, okay? And we had three variables. One was the glucose. So if your 1 hour glucose was greater than 155, and as I said, I think that's the best predictor of eventual diabetes, we divided it as to mild, moderate, and severe. And we then used the Matsuda Index of Insulin Sensitivity, which is just based on the insulin glucose. And we used the Insulin Secretion Index, which is a rise in insulin per rise in glucose multiplied by your insulin sensitivity, okay? And if you just plug in the glucose and insulin values, you'll get the insulin sensitivity and insulin secretion. So the grading system is if you had a severe defect in 2 of these, or a severe defect in 1 plus the other 2, you got the triple therapy from the beginning. If you had none of these, you're at low risk, okay, you were assigned to lifestyle, except for a few patients who are not so smart, you'll see. And then all the others that were intermediate got pioglitazone or metformin. So this is what happened. If you got the lifestyle, and look, this is a long follow-up, it's 100 months. If you got the lifestyle intervention, okay, and you were in the group of people who were told you're at risk, but you declined the pharmacologic therapy, and you said, okay, I go for the lifestyle, over 100 months, 60% of them developed diabetes. So they weren't very smart at all, okay? So here are the people who got pioglitazone and metformin. You can see about 20%. And here are the people who got the triple therapy. Now, that orange line is a misconception, okay? And I'll show you in a second. Because not a single person in the triple therapy group developed diabetes. But you can't do statistics when you have an N of 0. So if you read the paper, which is at the top, you'll see in the paper we said no one developed diabetes, but to do the statistics, we assumed that 1 person developed diabetes. So with an N of 1, you can do the statistics. So here is the incidence of type 2 diabetes in the lifestyle people who rejected the pharmacologic therapy, the people who got pioglitazone and metformin, and the triple therapy. Not a single person over 100 months. So if you intervene early, you can markedly slow or stop, okay? Now, there were people who got lifestyle because they weren't at risk. They weren't insulin resistant. Their 1-hour glucose was less than 155, and their insulin sensitivity was normal. You can see their risk over 100 months to develop diabetes is very low. So that lifestyle group was okay. But these were not so smart people who said, oh, I'll do the lifestyle. I can beat this. Well, they were a little bit wrong. So this comes back to this now issue of when do you start. So we coined this word pre-diabetes. And this is a result of a meta-analysis we did that was in the literature. This is a young endocrinologist from Thailand. And this is a very large study, 19 publications, 41,000 individuals. And these individuals, to get into this study, had to have a myocardial infarction, okay, and no prior history of diabetes or any type of glucose intolerance, okay? So now you come to the emergency room, you've had, you got Q-waves, ST elevation, you had an acute MI, all right? And so now we're going to wait 10 days, because if you do an oral glucose tolerance test in the acute MI stage, you're stressed, catechols are up. By 10 days later, things have kind of returned to normal. So of these people, these 41,000 people, half of them who had their MI, they had normal glucose tolerance when we did the OGTT, okay? The other half had either prediabetes or diabetes. Well, if we now look at the people who had prediabetes, something had to have happened before they developed prediabetes. They're coming in with their MI, means for many years before they had prediabetes, something was going wrong. And the something was going wrong is the insulin resistance and the components of the metabolic syndrome. So we actually have, now in a meta-analysis of 19 published studies that says that this disease, particularly from the atherosclerosis standpoint, starts long before you develop diabetes. I showed you earlier with the insulin clamp. You are insulin resistant in the pre-diabetic stage. I showed you with beta cell function in the range of normal glucose tolerance. You already have a more than 50% decline in your beta cell function. So it should be pretty obvious that there is a pre-diabetic state, both for the development of diabetes and also for the development of cardiovascular complications. So this is what we call the ticking clock hypothesis, okay? The complications for, or the risk for coronary artery disease starts when you're born. You just got some bad genes that predispose you to atherosclerosis, okay? The complications for diabetes, they can't start until you become hyperglycemic. So you are at long risk for cardiovascular disease, but at least for the microvascular complications, they're related to the hyperglycemia. So I told you I would start with a question, and then I would end with a question. And again, there's no right or wrong, okay? I can tell you that all of what I presented is all published. So who now would start and wait till the person develops diabetes? Okay, that's not my hand going up. Who would start at the pre-diabetes state? And I think that's quite reasonable. Who would start at the pre-diabetes state? Okay, so there are some hands that went up for the pre-diabetes state. So again, the goal of the questions was not necessarily to change what you're doing, but at least to get you to think that really maybe we ought to start to think of treating at an earlier stage. And you know, the American Diabetes Association has debated this many times. The one way to sort of solve the problem would be just to change the diagnostic criteria. So we could establish that instead of saying diabetes when your A1C is 6.5, we say 5.7. I think that's reasonable. So why'd they not do it? Because the economics that are involved, if you had to treat everybody who had diabetes with an A1C of 5.7, would be huge. So it would break the Medicare budget. So in large part, economics is playing a role here. But let's say you had this patient in your practice. The patient is 45 years of age. The A1C is, say, I'll give you an intermediate one, 6.2, still higher. The mother had a myocardial infarction and died at age 45. The father had a stroke and died at age 51. Would you treat that person? I, for sure, would treat that person. So a lot of times, you're going to have to use your clinical judgment. There's no right or wrong. You look at the composite history, the background, and I would say if this is a high-risk person, sure, I would treat. What are the treatment choices? Well, you could use, I mean, everybody's going to use lifestyle, okay? That goes without question. Would you use metformin? Yeah, I probably wouldn't, but it's not a bad choice. You could use low-dose pioglitazone with or without metformin. And if the patient is overweight, you have the GLP-1 receptor agonist. So this is what I would say, food for thought. There's no right or wrong answer. So I think that is the last slide that I was going to show.
Thank you so much.